and thank you, Geraldine, for sharing. So I'm Sarah Davison, and I'm here on behalf of the Kidney Supportive Care Research Group and the Northern Alberta Renal Program to share our CKM pathway with you. So we know that in Alberta, our patient population is aging, and we are more likely to develop chronic illnesses like kidney failure. But most of us, or many of us, are going to develop several serious illnesses. And unfortunately, it's patients like that that have numerous chronic illnesses that don't necessarily do well after they start dialysis. However, those patients with lots of illnesses who become quite frail, if they are treated conservatively, can actually do very well without dialysis and live as long, if not longer, with preserved function, quality of life, without the burden associated with dialysis. They have not just better quality of life, they have fewer admissions to hospital and overall can do quite well. Unfortunately, most healthcare providers and patients don't know that this is an option, and therefore they feel they have no other course but to start dialysis. Unfortunately, the solution is not just as simple as to show patients that they have a choice. And this is really illustrated by Bob's case. So Bob was a 78-year-old man who had kidney failure, and he was cared for in our kidney clinics and was very clear about his decision not to start dialysis. But he also had liver failure. He required frequent taps of his belly to drain fluid. Then one day he presented to the emergency room, and he had accumulated fluid in his tummy, causing lots of abdominal pain and shortness of breath. He was admitted to hospital and started urgently on dialysis. So Bob, when we talked to him after, said that he was coerced into starting dialysis because the care team had said the only way to manage his symptoms was to put a shunt in the liver, and they would not do this unless he was on dialysis. So Bob reluctantly agreed. But a week later, he found out that they could not or would not do the shunt. So he was left on dialysis, but having to remain with weekly taps. Not surprisingly, Bob did not do well on dialysis. He had recurrent nausea, vomiting, cramps. He rapidly deteriorated and had substantial post-dialysis fatigue. And so shortly after, about a month after starting dialysis, he decided this was not for him, and he stopped. He went back to the clinic. He was cared for at home, and he died 4 weeks later. So even for patients like Bob who know what they want, our healthcare system failed him. And I think his experience really highlights our lack of general awareness or coordination of services around a more supportive philosophy of care. So it results in very high rates of hospital admissions and use of these aggressive therapies that are not well aligned with patients' preferences, that provide little, if any, benefit, and in Bob's case, substantial harm. So our challenge was to develop, implement, and evaluate an integrated approach to care for patients like Bob who choose no dialysis. And our real focus is ensuring all their care remains aligned with their preferences, that we decrease their symptom burden in order to optimize their physical function and their quality of life. We want to make sure that patients and families remain satisfied with their care. We want to shift away from unnecessary use of acute care resources to care for patients where they want to be cared for, which is typically at home in their home communities. And we have to stop practicing in silos. We need a shared approach to care, coordinated care. So our solution started with really bringing together everybody, all our stakeholders, which started with patients and families and having them work with our frontline staff to identify what were all the barriers, what were the facilitators to optimizing care for our patients. And we did this through a series of highly interactive sessions using world cafes. And through that, we were able to get all the pieces, like the pieces of a jigsaw puzzle, that we were able to put together that built this interactive pathway. And this way, the pathway was truly co-designed by not just patients and their families, but also by all the people involved in their care throughout their illness trajectory. Our pathway really consists of two main components. There is a patient decision aid that allows healthcare providers and patients to actually determine what is the right care for them. Is it dialysis or no dialysis? And then you'll see on the screen there's two portals that the next part is really about integrated communication and care plans that are meant to be individualized. And you can have a healthcare provider portal, but the patient said, we want our own portal to be able to navigate this website ourselves. This is a snapshot of the interactive patient portal. And through this, patients are able to navigate their decision aid if that's where they're still struggling to make the right decision for them. All the educational materials are here, including their symptom management protocols, but they really focus on what can the patients and the family members do at home to manage their own symptoms before they even start medications or in addition to medications. We've got streamlined referrals from home care to home palliative care. It's a matter of, they said, we want to know what do we do in a crisis, who do we call, who do we ask for help, and we leverage provincial support such as EMS, assess, treat and refer, so if 911 is called, we can keep them at home. So in terms of our success, early success shows a huge increase in the uptake of conservative care because now we have a positive set of treatment options to offer patients. But most importantly, patients are happy with this care and they are staying on the pathway until death, as opposed to patients like Bob crash landing in Emerge and starting dialysis. We're managing their symptoms, but most importantly, our patients are satisfied. We want to make sure patients and families are satisfied that they received the care that was most important to them. And so I'm going to share the story of both Jack and Jody, and his daughter's with us today. Thank you, Jody.
This is the end of someone's life, but he was finishing well, and there was no regret for me. I think of my dad as a courageous, loving man, and I'm so grateful that he let us experience life together right to the very end, and his attitude was one of being positive and of looking at how he could bless somebody else. My dad was diagnosed with kidney disease a good 20 years before he actually died. 5 years ago, he was still in the route of just looking after his kidneys, and then things started to progress. My dad had other challenges. He had fallen, he had had pneumonia, and had been hospitalized. We talked about this conservative management with the doctor, and it seemed like this was the right thing for us, for most of the part. But when my dad would end up in the hospital, we'd often run into physicians who would always talk about the dialysis with him. That was hard. That was hard because you kind of second guess yourself. You know, have I done the right thing for my loved one? Because I'm the support. I want to be this cheerleader in the background saying, you know, like, let's do whatever we can do. But every time I had the doubt in my heart, I would check the conservative kidney management website. It would just kind of stabilize me, and I'd go, okay, this is normal, this is what he's experiencing, check, check, check. Or I would also phone the conservative kidney management team. There is like this multiple staff of professionals, you know, the dietitian, if I had a question, or the pharmacist especially, I leaned upon heavily. And so I would often go over these things with them. My dad's last stint in the hospital, he had fallen and broken his hip. We were aware that there were other people on that ward that were actually going down and getting their dialysis done. And my dad was just like, oh, you know, I'm glad it's them and not me. I'm ready to go. Like, you know, you don't have to try to keep me here forever and ever. He didn't hold back from much, you know. His life was full and complete, and that's what we wanted for him, was a full life.
So now our work is going to extend to patients with other chronic illnesses. So most of us are going to die with heart, lung, liver, kidney failure, or cancer. And like Bob, many of us will have more than one health issue. So we are adapting this pathway to meet the needs of patients with all these other chronic illnesses, realizing that they share many of the same elements of care, but will require some specialized decision making and some specialized symptom and medical management. And then we will be implementing this at the level of primary care across the province to enhance both patient and community capacity. And I really want to extend a huge thanks, firstly, to our patients, who are without a doubt our greatest teachers, and then to the tremendous group of people I work with, including the Kidney Supportive Care Research Group. So Vanessa Steinke, our Senior Project Manager, who's here today, and Jody, who you just heard from, one of our patient partners, and all the amazing frontline staff in all of our kidney clinics in the Northern Alberta Renal Program, who really brought this pathway to life and made it a reality for our patients. Thank you.